Hello, everyone, and welcome to Preemie Chats, a space where we connect, learn, and share stories about the world of prematurity. I'm Leah Whitehead. I'm the proud parent of a preemie, and I'm also a former journalist. And I'm so honored that you have chosen to join us here today. Preemie Chats is brought to you by the Canadian Premature Babies Foundation, also known as CPBF, a parent-led charitable organization dedicated to supporting families, advocating for the needs of premature babies, and providing the latest information and resources to help parents and caregivers navigate this journey. So whether you're a parent, a healthcare professional, a researcher, or someone interested in understanding more about preterm birth, you are in the right place. Together, we're creating a supportive community where stories are shared, questions are answered, new evidence is explored, and no one feels alone. Be sure to visit our website. It's on the screen, canadianpreemies.org. And there you'll find helpful resources, our latest projects, and most importantly, a community of people who want to see our little babies thrive. If you're watching live today, I'd invite you to please join the conversation. Share your questions and comments in the chat, and we'll try to address them during our program today. And if you're watching a recorded session, you can still connect with us through our website. It's through meaningful discussions like the one we're about to have, where we advance practice and grow together. So let us know where you're watching from. We'd love to hear from you. I see Sandy, you're already saying hello and letting us know that you're tuning in. So I'd invite other people to do the same. It's always interesting to see where people are joining us from. Now, the topic we're exploring today is one of the reasons why I love hosting Preemie Chats. Every time I learn something new, and I hope you will too. As parents, we deserve the bigger picture when it comes to treatments or medications for our little ones. And I have always been the parent who asks a lot of questions. So I was honestly shocked to learn this. When we left the NICU, like many families, we were sent home with vitamin D drops to give to our preemie for her first year. And most of us already know vitamin D is important. It helps build strong bones and supports so many essential functions like immunity, reducing inflammation, and even fighting infections. But what I didn't realize is just how critical vitamin D is when it comes to respiratory health. Research shows that vitamin D levels are inversely linked to the risk of respiratory disorders in infancy, especially those caused by RSV and other viruses. So, in other words, keeping vitamin D levels where they should be offers a layer of protection for our babies. And here's something else. It's not only important for preemies and young infants, but also for those who are pregnant. When a mother's vitamin D levels are healthy, she passes those benefits on to her baby through the placenta, giving her little one a stronger start even before birth. To help guide us in our conversation today, we are joined by Dr. Paolo Manzoni. Dr. Manzoni is a neonatologist and pediatrician, serving as the head of the Italian Society of Neonatal Infectious Diseases and a founding board member of the ResVNet Excellence Research Network on RSV, and that was established in 2014. He spent over 2 decades as part of the neonatology and NICU team at St. Anna Hospital in Torino before becoming head of the maternal infant medicine department at the University of Torino Hospital, degli Infermi in Biella. He also holds a position as Associate Professor of Pediatrics and Neonatology at the University of Torino's School of Medicine. And I'm so happy he's joining us here today to share his wisdom. Welcome, Paolo.
Thank you very much, Leah. My pleasure to be here and to join you for the second time. Last year I came here and I gave another talk, and it was a wonderful experience. And so I'm proud and honored to be here once more to highlight these very interesting points that Julia summarized amazingly well, because probably you said it all and I have no more room to explain further, but I will try to cover some minimal areas that you couldn't include in a summary. Let's go straight to the point, vitamin D and respiratory morbidity. And I underline the word "and" because that means that vitamin D is associated inversely or in other forms with respiratory morbidity in infants. Next one, please. Next one. Okay, I have no disclosures about this lecture. Next one. And this is the outline. I will cover briefly what vitamin D is in terms of structure, intakes, actions, and benefits. And then I'll go straight through the point of this lecture, respiratory diseases and association with vitamin D, which are the links, is, if any, and how can we, and this is the point of practical guidance, use this information to better address our cares and our preventative strategies to pregnant mothers and to neonates and young infants. Next one. So let's go straight to vitamin D. Next. Vitamin D is a liposoluble hormone. Hormones are substances, as you probably know, that are secreted by the body internally and are delivered internally to one or more organs, other organs, to deploy a specific effect. And vitamin D has a reservoir in the skin. In the skin, vitamin D is diluted in the fatty layer of the skin, in the surface, in a form that is called vitamin D ergocalciferol D2. And this D2 form of vitamin D is a precursor. In chemistry, we call it the provitamin. That means that in this form, vitamin D is not yet active, but needs activation. And how can we get activation? Probably you know it very well, through the sunlight. Sunbeams activate vitamin D2 into vitamin D3, so-called cholecalciferol. And this form, the D3 form, becomes ready for being transported into the whole human body and being ultimately ready for intestinal absorption if we get an oral intake. So you understand clearly, right from this slide, that we do need the sunlight in order to have active vitamin D. Next one. In fact, the sources of vitamin D are mainly related to sunlight exposure through the UV rays, because more than 80% of the vitamin D that every human being is using comes from there. If we want to, let's say, to improve a little bit our vitamin D content, our vitamin D storages, we can ingest vitamin D and count on the intestinal absorption through meals or nutrients that are rich in vitamin D. Oily fish, number one, dairies, but most of all supplements and fortified milk, cereals, or bread. However, the intestinal absorption accounts for no more than 20%. So it's not that easy to overcome and to restore a poor exposure to sunlight if we are not very, very actively focused on providing the correct intakes through oral ingestion. Next one. And geographically, we have areas, and sorry for this new, you guys in Canada belong to an area that in this view is neglected. We have very many geographic areas at the extreme of the two hemispheres where the exposure to sun rays is poor. I would like to say is inherently poor because the latitude implies that the rays do not arrive with the correct potency and aren't able to transform vitamin D2 into D3 in all molecules. In contrast, in countries from both sides of the equator and up to the Mediterranean side or the sub-Saharan continent or Central America or Far East, the sun exposure might be good, but however, there are other ways to decrease the sun exposure despite the geographical location is suitable. And these other ways are pollution, number one, and cultural habits to wear long dresses and to wear dresses and clothes who do not expose the skin, like in Arabian countries. As a whole, you can see from this geographical map that the problem of vitamin D deficiency may affect every human being located in every geographical area, both for either for poor geographical sun exposure or for cultural or environmental habits or conditions that prevent correct exposure to the sun. Next one. But which actions does vitamin D exert? The roles of vitamin D are very many, and you know very well that calcium and phosphorus homeostasis ultimately activity on the bones is the number one action of vitamin D, thus preventing rickets, osteomalacia, and osteoporosis, especially in elderly. But just as Leah was alluding to, there are several other actions of vitamin D. It's an hormone, and it's very active in regulating the immune system, in promoting innate and adaptive immunity, in delivering good cognitive health and well-being, and in contrasting infections, especially in the respiratory domain. Next one. Vitamin D deficiency is diagnosed by measuring the levels of the active isoform in the blood. And unfortunately, vitamin D deficiency during childhood is very frequent. You see here, and this is partly in Italian, but it's very easy to understand, that levels below 10 nanogram per milliliters, levels that are indeed very, very low, are very frequent also in Italy. And this graphic comes from Italian children, despite geographical correct location. And if we want to give figures, up to 50% of children might be in slight or huge deficiency of vitamin D, according to these studies. Next one. Obviously, skin sun exposure accounts heavily for the deficiency. And this is true also in geographical good location during winter season. You see here that during fall and winter and early spring, the levels of vitamin D aren't correct in those babies and those individuals living in northern or southern hemispheres, and therefore, at the very least during winter time, a deficiency of vitamin D might occur also in areas where the sun exposure is correct. Next one. I don't want you to remember very accurately this table, but in routine daily practice, we usually define deficiency levels of vitamin D that are less than 25 nanomole per liter. And when we detect these levels, the action is to replace vitamin D rapidly and hugely with even loading doses followed by maintenance. However, a big proportion of children is falling within the range of insufficiency, that is 25 to 50. And in these levels, when these levels occur, these children are given maintenance doses or loading doses if they are affected by additional morbidities affecting mainly the bone system. When the levels exceed 50, we define the vitamin D as repletion and the baby as not having any need for replacement or for continued dosing. However, please remember that just like every liposoluble hormone, vitamin D might be even toxic if levels exceed 150 nanomoles. This is a very rare, a very unusual and uncommon feature, but however, we do always need to manage this possible problem and to handle with care administration of vitamin D, especially when we think to give loading doses. Please go on, the next one. So, after having highlighted what vitamin D is and which are definitions of deficiency and insufficiency, let's go to see whether there is a link between vitamin D and respiratory disease. Next one. And indeed, the links are there because vitamin D has a lot of extraskeletal actions with, as I was telling you at the beginning of this talk, immunomodulatory actions, interference, positive interference on the development of autoimmune diseases, promotion of innate immunity, and actions also in the inflammation chain. Next one. Especially, I want to spend a little minute on the actions on immune system and on inflammation. Vitamin D has indeed these effects, and these effects can be measured when we go and detect an increased occurrence of respiratory tract infections in individuals affected by vitamin D deprivation, particularly in developing countries where several papers have shown this feature. But we do have also an increased risk of wheezing in infants less than 3 years old, and an increased risk of viral co-infections in those children who are recurrent wheezers. Let's go through some of these papers and studies in order to understand more deeply this point. The next one, please. Vitamin D has effects on the immune system, and this is implying that vitamin D can modify and imprint the development of monocytes and macrophage, can enhance the maturation of the dendritic cells, can affect on the memory T cells in both ways, and can also activate the proliferation of B cells. So a wide range of actions ultimately conveying an increased ability to defend from infections, especially for the child. Next one, but also on inflammation, we have a demonstration that inflammation, especially in lung epithelial cells, can be decreased by having good levels of vitamin D. And this is due mainly to an interference of vitamin D against the TNF alpha, the tumor necrosis factor alpha, a key player in the inflammation cascade. Next one. With this in mind, let's go next one to see which are the proofs. And I was telling you that wheezing and wheezers can be somewhat associated with vitamin D deficiency. And indeed, this study in Finland, in the JACI by Dr. Jarti, already 15 years ago, they could see that when vitamin D levels were lower than 50 nanogram per milliliter, an increased risk of viral infections, mainly by RSV and rhinovirus, was occurring in children who were hospitalized for wheezing. Next one. But more concerningly and more curiously, vitamin D deficiency can be a cause or can be associated, at the very least, with an increased risk of respiratory infections in neonates since the levels in the cord blood. Several studies, and this is one of the very first published in pediatrics, have measured the level of vitamin D in the cord blood soon after birth, or I would say immediately after birth. And when these levels are falling within 25 nanomole per liter, meaning that there is a deficiency, well, these babies have an evolution that is very typical. They go very frequently towards respiratory infections and towards wheezing and viral infection during wheezing. So the point is already there since birth. Next one. And this is another graphic from this study assessing that this risk may be prolonged up to 5 years of age if having low cord blood levels is not corrected during the first months and years of life. Next one. Also, in bronchiolitis, there's a relationship with vitamin deficiency. Children with acute bronchiolitis have more frequently low levels of vitamin D. And this is a case series from Israel, published in BMC Pediatrics, where out of 80 babies with bronchiolitis matched with a control group, the vitamin D levels in the bronchiolitis group were as a mean 28, that means on the borderline of deficiency, whereas the control group had 50. So this is a clear difference vouching for a role of vitamin D, not only in providing a higher likelihood of being hospitalized for bronchiolitis. Next one. But also a higher severity of bronchiolitis once this baby is hospitalized. And this is again another very interesting picture of this population of babies hospitalized with bronchiolitis, where we see very clearly that the severe course of bronchiolitis is occurring always in babies with deficiency of vitamin D, and the moderate feature is occurring again in babies with a high proportion of vitamin D deficiency. So vitamin D deficiency is impacting very much on bronchiolitis, both in terms of frequency and in terms of severity. Next one, thanks. But more, I would say more specifically, RSV can be a key player in this context. You know very well that bronchiolitis, and we come back to the previous two slides, is mainly caused by RSV. So the suspicion that RSV and vitamin D may be linked is very high. And we have several hints vouching for this suspicion from in vitro study, from genetic polymorphisms that have been detected. And most of all, from once more the measurements of vitamin D in the cord blood and the follow-up of these babies born during different months of the year with different levels of vitamin D in their cord blood. X1. One of the most important studies assessing these relationships has been conducted in the Netherlands some 10 years ago. It was published by Pediatrics. This is the group of Louis Bont, the chair of the ResVinet network, which I belong to. In this Dutch study, a prospective birth cohort was followed up with 156 neonates, and they were followed up during their first year of life with measuring cord blood vitamin D concentrations at birth, and later on with reporting from the parents about RSV symptoms occurring in the first year of age, and the detection of RSV during episodes with the symptoms of respiratory disorders. Next one, please. Okay, we have a number of very interesting findings coming from this study. First of all, the levels of cord blood vitamin D were clearly associated, and you see this graphic with a red arrow, with the months of birth, meaning that babies born during winter had higher level of vitamin D simply because their mothers have been exposed, potentially more exposed to sunlight during the summer months when they were pregnant. Conversely, babies born during summer months were having more frequently low concentrations of vitamin D in the cord blood. Next one. And this exposure during pregnancy was clearly translating on the levels of vitamin D in the cord blood, in that the frequency of deficiency of vitamin D less than 25 was higher in babies born during summer than during winter. So we might think that Mother Nature is providing a natural support for those babies being born during winter time because their mothers should have been exposed to sunlight and therefore delivering more vitamin D when the delivery occurs. Next one. And curiously enough, this curve of vitamin D levels, as you see in the right, according to different birth months, with a peak during winter months, is fully overlapping with the peak of circulation of RSV during winter months. You see, they both are clearly the same. So the natural model of protection against RSV, at least of a very basic protection against RSV, is giving value to this natural model of having high vitamin D cord blood levels during months where RSV exposure could be the highest. And therefore, this is a first call to action because we should advise pregnant mothers expected to deliver during the fall and winter to get exposure to the sun during summertime when they are 4, 5, 6 months pregnant old, and to receive supplements if this exposure is not enough. Next one. But the final confirmation of what I'm saying is that when following up these babies for the first year of life, it was absolutely more frequent having a lower respiratory tract infection by RSV in those children being born with low levels of vitamin D compared with those who had good levels. And therefore, having less than 50 nanomole per liter was already conferring a fourfold higher risk of having a respiratory RSV infection than having levels beyond 50 nanomole per liter. Next one. In conclusion, the deficiency of vitamin D was very frequent in Dutch newborns in this study, and the concentration of vitamin D in the cord blood were associated clearly with the susceptibility to develop an RSV LRTI during the first year of age. And therefore, since vitamin D status depends on the maternal status, particularly during pregnancy, we need to provide vitamin D supplements during pregnancies in order to increase the cord blood vitamin D concentration. And we need to reinforce the message and to promote the awareness about what vitamin D can give to each single offspring after delivery, in order to have mothers during pregnancy very well concerned and very well engaged with prophylaxis with vitamin D. Next one. And if we don't have good levels in the cord blood, can we correct this mismatch? Yes, we can. We can by giving supplementation of vitamin D since birth and full adherence to the recommendations and guidelines that are very strict and very mandatory. Effect of vitamin D supplementation can be seen after a few months of supplementation, and here we have the results of a BMJ study where 6 months of vitamin D supplementation were able to convert 80% of the babies belonging to the vitamin D deficiency group in babies having an adequate level. Next one. So I'm coming to the end, and I would like to close this lecture with some call to actions that are the main messages that you can bring home. So the status of vitamin D needs to be assessed in all pregnant women. So OBGYNs, midwives, and pregnant mothers need to be fully aware about that. Supplements in pregnancy are critical and are required to avoid vitamin D deficiency in the offsprings, besides exposure to the sunlight whenever possible by pregnant mothers. Vitamin D after delivery needs to be supplemented in all infants. The risk of overdosing is really negligible. At the very least, it's not there when we are sticking to the correct dosing recommendations. Whenever vitamin D deficiency occurs, respiratory morbidity in infants increases, and RSV is one of the main actors, if not the main one, in this context. Therefore, and this is my last message, prevention of RSV bronchiolitis relies very much also on vitamin D correct intakes and possibly on supplementation of vitamin D in pregnancy and in infants. Next one. And having said that, I thank you for your attention, and I'm very happy to promote here and invite you here the next ICCN, International Conference of Clinical Neonatology, that will be performed in Torino, Italy, on next September 2026, in collaboration with ResviNet, the network of experts on RSV, which I belong to. Thank you very much, and I'm happy to get questions if you have any.
Thank you very much for your presentation. I was taking lots of notes. I have lots of questions. Some of them you did answer in your presentation, so that was great. And we did have some questions come in from Sandy, who's watching, and she wondered, you talked about the importance of doing blood tests to kind of monitor the vitamin D levels. I think to avoid toxicity was the purpose there. And so she was asking, how often should you do the blood test to know the vitamin D values?
Well, I would be very easy about that. The vitamin D blood test may be done only once in order to have a picture of your status and then move from there. The risk of having over dosages, as I was telling earlier on, is really, really negligible. So unless you get 5 shots of millions and millions of international units of vitamin D, this is almost impossible. But it's very important to have a picture of the baseline status. And very often this picture is giving us bad surprises because we are not aware of being deficient, and we might be in turn.
Sandy also had a question about the pregnant woman intake vitamin D time. And so should they be starting in early pregnancy? And I think you mentioned sunbathing can help provide additional vitamin D.
Yeah, sure. So I recommend giving vitamin D during the whole pregnancy. Once more, with the correct dosing and dosing regimens. And these dosing regimens are absolutely fine and absolutely safe. Obviously, if you have the chance to get some sun by using short sleeves, skirts, and not having hats or big hats, that's an additional advantage if you can have it because you are living in a geographically suitable area.
I had a question just about, so again, the timing. We did vitamin D drops for our preemie when we I think it was partway during our stay in NICU, if I remember correctly, but I'm going back 12 years now. And then when we were home until she was 1. And I'm just wondering if that kind of practice, like, should that go longer than a year? Or are you finding that that tends to be the sweet spot for our infants?
No, I tell you, it's important to prolong this practice at least till school age for many reasons, especially if you live in urban areas. Well, I live in northern Italy. Northern Italy is okay. We have a sun exposure during summer, but then we have a long winters with the pollution, with fog, with heavy clothing, and therefore vitamin D is critical also beyond the first year of age. Is very critical at the very least up to the school age, because during the first 5 to 6 years, children are very prone to respiratory infections, and therefore we do need that. And additionally, we recommend strongly a vitamin D supplementation when the pubertal burst is occurring. So during the puberty and early adolescence, both for reinforcing the bone bone system, and also because in adolescence immunity may be waning a little bit, and an additional protection can be helpful.
Hmm. It's funny, you always hear vitamin C talk with the immunity and have your oranges and your juice but it sounds like vitamin D is a good bolster for that as well, and something that maybe isn't as commonly shared or talked about.
You know, you touched a very nice point. Vitamin C is mainly an anti-inflammatory nutrient, so
Mm.
it's able to decrease inflammation, but it's not able that much because it's an antioxidant. Vitamin C is ascorbic acid, and ascorbic acid is an antioxidant. By decreasing oxidation, at the end of the day, you decrease inflammation, so you get relieved from your symptoms earlier. In turn, vitamin D is an hormone delivering actions on several organs, including the immune system. So it's really something more besides being something different.
I'm wondering about long-term effects as well, because especially for preemie parents, a lot of us have babies who then receive the diagnosis of chronic lung disease and go on to be asthmatics. And
Yeah.
so, is this something that would affect long-term health? And is it something that could help with something like asthma as well?
Yeah, so the studies that I provided, I took a sample, a very limited sample of the studies, but there are many more. Those studies vouch for an association between low levels of vitamin D and wheezing, recurrent wheezing, asthmatic episodes complicated by viral infections, and so on. So a comprehensive picture of increased morbidity in the respiratory domain in the first, at the very least, in the first 6 years of age. And obviously, if you have a baseline condition that is already hampering you, um, it's the role of vitamin D might be even more meaningful because this could help preventing a little but not a negligible portion of worsening related to your baseline condition. So, as a matter of fact, at least in Italy, we all neonatologists involved in follow-up of preterm neonates after discharge from the NICU uh, used to have a very high attention towards vitamin delivery and intakes, and number one is vitamin D.
Hmm. And you're saying that all infants would be on vitamin D, not just preemies, is that right?
Yeah, absolutely, absolutely. Um, as I was saying a little earlier, preemies are, how to say, are more penalized. They have a baseline condition that it's already critical compared to regularly born infants, but both of them can receive benefits from vitamin D.
And you talked about the cord blood as well, which is very interesting because, again, it's one of those things that when you're taking, your prenatal vitamins, you often don't think that it will affect respiratory
Hmm.
systems down the road for your baby. And so I'm just wondering, with that cord blood, you had said that.
Hello? Ah, I lost you.
Hello?
Hello, yes, I'm here. Can you see me? Okay, I can see you. You got freezed.
It looks
Can
like we
you?
may have lost Paolo. He is in Italy, and so I thought it was running a
I
little too smoothly to be having this discussion with someone overseas, but we will wrap up our conversation there for the day. Thank you for joining us for this edition of Preemie Chats. I could have asked so many more questions because it is such an interesting topic and one that I think we need to be talking about and having these kind of conversations. A special thank you to Sanofi for their support of educational programs such as this one. And if you missed part of today's episode or you want to revisit it, you can find this episode and all past episodes on our YouTube channel and website. Again, CanadianPreemies.org. There it is on our screen. And while you're there, explore the many resources and support options that we offer to families on their journey. As a charitable organization, CPBF relies on the generous support of people like you. Your donations allow us to continue empowering families of premature babies every step of the way. Together, we can create a brighter future for all preemies and their families. And of course, speaking of brighter future, I know that you've heard about this. We are going to make a big splash this year leading up to World Prematurity Day. We have our gala happening November 6th in Toronto. If you're able to be there, be there. You won't want to miss it. We're going to have some very special guests, some meaningful moments together, a silent auction that we have all kinds of items that will be exciting to bid on. And so don't miss it. And, even if you think there's no way I can make that work, consider donating a ticket to one of our families who would like to attend, because it really will be a special evening to come together and shine hope for premature babies all across our country. Thank you for being a part of this community. We will see you next Friday at 1 p.m. Eastern Time for another live episode of Preemie Chats.